Hi, everybody, and welcome to another Friday webinar. I'm Nadine. I'm from the National Drug and Alcohol, the National Centre for Clinical Research in Emerging Drugs, and also from St Vincent's Hospital Alcohol and Drug Service. Just want to acknowledge the Gadigal people of the Eora Nation as the traditional owners of the land on which I'm seated today. Pay my respects to elders past, present and emerging, and any Aboriginal or Torres Strait Islander people that are with us today. And recognise that sovereignty was never ceded. Before we get going, I just want to hope that everyone's doing pretty well as we start to emerge out of this weird kind of COVID time. And we've been having a series of webinars talking about substance use during the COVID isolation period, and as we start to come out of it and what that means for our treatment sector and our service sector and people who use drugs and their families and their friends and carers. Today, I'm really fortunate to be joined by Jack Freestone from the AIDS Council of New South Wales, ACON. I might just hand over to you, Jack, just to introduce yourself.
Sure. So I'm Jack Freestone and I manage our alcohol and drug programs at ACON and also our mental health programs at ACON. So in our alcohol and drug programs, we run a range of services. We have needle and syringe programs in Sydney, in the Hunter and in Lismore. We also have the ACON Rovers program where we send volunteers out to dance parties and community events attended by sexuality and gender diverse people, and the Rovers perform a function of helping people to access on-site medical assistance when they need to. We also participate in a lot of research, and currently we have a research partnership with NCCRED, which is super exciting. Thank you, Nadine. And we have a substance support counselling service. So we do a lot of work in AOD at ACON, and that sort of sits within my remit.
Great, thanks, Jack. So today we're going to have a chat about GHB and GBL14BD, its precursors. And we next week we'll be lucky enough to be joined by some people that have been running surveys during this time to talk about people's substance use during what's happened to people's substance use during the COVID period. And we'll be hearing, including many drugs, but including people's experience of GHB. So today we're not going to talk about whether people have been using more or less G during this lockdown time, but what we are concerned about, I guess, is as we start coming out of COVID isolation, that we're really going to be looking for some social reconnection, and that might include using drugs that we mightn't have used for a while. And I guess one of the issues with GHB is the issue of tolerance and then the risk of overdose. It's a drug that's already associated with quite a number of overdoses. So I thought it'd be great if we could talk to you, Jack, about what you think. What are the sort of harms that we should be aware of associated with GHB use, and you know, what is a G drop?
Totally, good questions, and I think you're right, and I think it's good for us to start thinking about this period after COVID-19 as we come out of isolation. And I think we can, reasonably suspect that people might want to go for it a little bit, for lack of better terminology, that they might want to have a little bit of a party. So keeping our harm reduction tips in mind in relation to alcohol and other drugs, and GHB in particular, is really key. And just to take it a step backwards, I suppose, to think about why we're talking about GHB in particular, you've touched on a little bit there in terms of tolerance and overdose, but I just want to acknowledge that, at least from my understanding, there's been a lot of recent GHB presentations at emergency departments in New South Wales, and there's a sense that GHB is a drug that's been around for a long time in communities. And when we're talking about my work at ACON, we're always talking specifically about sexuality and gender diverse communities, and gay and bisexual men have been known to use GHB at higher rates for a longer period of time. But there's a sense that GHB is a bit of a drug of emerging concern. So just sort of to contextualize why it's important to have a discussion about GHB and for GHB to be on people's mind at this time. In terms of harm reduction and GHB as we come out of isolation, you've mentioned probably the number one concern already, Nadine, which is GHB is a drug which people can develop a tolerance to. So if you're taking GHB over a period of time, your dosage might increase to get the desired effect that you want to achieve. If you've not been taking GHB so much recently, there's a good chance that your tolerance is not where it was before, say, social distancing. And GHB is a drug with very small margin of error when it comes to dosing, in terms of a dose that can cause desired effects and a dose which might result in overdose. That margin of error is really small. So I suppose that's our number one thing that we'd want to advise people on if they are planning to consume GHB as we're coming out of isolation, is just be really mindful that your tolerance might not be where it was before, and to mitigate the risk of any overdose by dosing cautiously. So following that famous alcohol and drug harm reduction slogan of starting low and going slow. I nearly tripped up that one. But I also, the conversation we're having about this is kind of based on the assumption that people have maybe not been using as much recently. And I'm super excited for the episode next week, Nadine, to see what the researchers have to say about the data. I will admit I have had a little sneak peek and it is super interesting. So everybody should tune in next week. But there has been some data released from the Kirby Institute's Flux study that is publicly available about the numbers of gay and bisexual men who are having casual sex at this period of time. And we're seeing big reductions in the amount of casual sex that's being had because gay and bisexual men are following advice around social distancing in lieu of COVID-19. The reason why I think it's important to mention this when we're talking about GHB is because we know that GHB is a drug that can be consumed in sexual context. So it's one of the drugs that might be implicated in sexualized drug use, or party and play is potentially more community language for this. And so I suppose that would indicate that, if you're only using GHB in the context of having sex with other people, or if you're using GHB in the context of partying and socializing and going to a nightclub, if those things haven't been available to you for a few months, then, we can speculate that potentially you've not been using as much in recent months. And I also sort of wanted to talk about the casual sex thing and GHB as we come out of social distancing. I need to make it clear kind of what ACON's position on casual sex is at this time. So ACON still very much recommends and states that the best way to prevent COVID-19 transmission is to not have casual sex. That's sort of sex with somebody who's not a regular partner already, or and someone who you're not living with. And that's still the advice. And the guidance is that if you are planning to have casual sex as we come out of COVID-19, you can reduce risk of COVID-19 transmission by having sex with fewer partners, and making sure that you're keeping the contact details of those partners that you are having sex with, so that can assist with any kind of contact tracing efforts.
And are there other things that ACON's also recommending? I guess one of the concerns that we might hear next week from Kirby is the use of PrEP might be going down during the isolation time. So are there other kind of general health promotion recommendations that ACON's making to keep safe and happy as we move out of COVID?
Yeah, that's a really good point about PrEP. And certainly we've heard from communities anecdotally that people have maybe made decisions to stop taking PrEP if they're not having casual sex. If they're perceiving there's not a risk there, then why keep filling scripts for new PrEP or taking PrEP that's already there? And I think that's a reasonable decision to take. There is a little bit of guidance in terms of stopping PrEP and starting PrEP again. So if you're a gay or bisexual man, and if you stop taking PrEP, you should stop taking PrEP for 48 hours after your most recent incident of casual unprotected sex. But if you're from another community, if you're not a gay or bisexual man, you need to keep taking your PrEP for 28 days. So the guidance differs based on different populations. So that's one sort of point.
And how soon in advance do you need to start it?
That's a great question.
That's
That's the other side of the coin, isn't it, Nadine? So
Yeah.
the guidance now says for gay and bisexual men to start taking your PrEP 48 hours before to be totally protected. And if you're not a gay or bisexual man, then taking for 28 days to be fully protected. Yeah.
So that's quite some planning for some people.
Yeah, so it's just really about thinking about what your other HIV risk reduction strategies are. So if you're not being protected from HIV from PrEP, then what are those other risk reduction strategies we use? Is that condoms? Is that a conversation with a partner who might be HIV positive about undetectable viral load and whether they're on treatment? Is that, yeah, there's a range of HIV prevention strategies that we all have in our toolkit. So being really mindful about that if you decide to stop taking PrEP.
And I guess because we're talking about GHB, could GHB influence some of those kind of health promotion plans that you might have had in your head before when you thought about this last week and putting them in place? Is there a relationship there with GHB?
I'm not sure I entirely understand the question, Nadine, but are you getting at the notion that we don't always plan, like what's happening in terms of our sexual contact and things can happen unexpectedly, or? And
then also if you're more out of it than you had expected or planned, your capacity to actually negotiate safer sexual practices might be certainly some of the people I've spoken with have been concerned about exposure risks when they've been too intoxicated to negotiate, and issues of consent as well in that space, and thinking about how much do you use to prevent that kind of happening.
Yeah, you raise a few really good points there, and I think that that consideration around the way you're making decisions sexually and what you're comfortable with is something that can absolutely be implicated when we start talking about sexualized drug use. So I suppose checking in with yourself before a session and being conscious of where you're at and what your boundaries are is really key. And I'd be that intersection between sexualized drug use and consent is an interesting one, and I'd be really interested to know more about how diverse communities of sexuality and gender diverse people experience and understand GHB use in relation to issues of consent. I'm not sure that we have concrete data about that intersection, but I do know that there are specific issues around sexual assault and consent, and it is certainly a concern. And we know that there can be specific challenges around navigating issues of consent and sexual assault in environments where sex and AOD use is concurrent. We also know that there's some portions of our communities who experience sexual assault and sexual violence at alarmingly high rates. So the 2018 Trans and Gender Diverse Sexual Health Survey from the Kirby Institute found that 53% of their study cohort, which was a cohort of about 1,600 trans and gender diverse people across Australia, had experienced sexual assault or sexual violence. And many of people who were responding to that survey had experienced sexual assault or sexual violence multiple times. So these are really harrowing figures, and it's certainly a conversation that we need to be having as a community and also as a services sector. In terms of cultures around sexualized drug use and consent, I mean, I think as participants in those spaces, we have a duty of care to ensure that they're safe for everyone who's involved. And we have a duty of care to ensure that consent is being practiced and that there's a recognition that someone's presence in an environment like that isn't implied consent, and that consent is a continuous process. And to people who, have maybe experienced sexual assault or, who have experienced sexual assault or sexual violence, we need to understand that everyone's going to respond in a very individual way to that. Some people will want to see a medical professional, including a sexual assault service, but other people might want to see, follow a judicial process and, seek the police. I think there's some, if anyone's interested, ACON has just released a really excellent resource about this stuff. On the TransHub website, there's a whole web page about sexual assault and consent, and it talks through a lot of these issues in detail. So I could recommend people go and check it out.
Well, we can pop that on our website for this webinar too. So that's so, what are some of the other ways that you think people can create a safe environment for themselves as they're moving out from the COVID isolation? You talked about thinking through your own boundaries, but are there other kind of environmental things that you're recommending for people to? We've heard of group sex settings where one person has been kind of the nominated G nurse, if you like, or there are other kind of strategies that people can employ in different settings.
Absolutely. Yeah, absolutely. That's a good question. And I think that what we see in sexuality and gender diverse communities around AOD use is really strong cultures of care, and what you've just spoken to about being the G nurse is a really good example of that, like an example of an embodied practice where people look out for each other and help each other. And I think those practices around safety in terms of having someone, the notion of the G nurse is that person who usually controls how much people are dosing and when people are dosing, and maybe is present in that space but isn't necessarily partaking in the same extent. So that's a really good strategy. And I think a few other things in terms of creating safe environments around G use is being really mindful of what containers you're keeping your GHB in. So making sure that you're not putting it in containers that can look like drinking instruments. So clearly marking those containers so that you can be sure. I think also being sure that when you're measuring your GHB that you're using different syringes, because GHB is like an industrial strength solvent and it can quite easily remove the measurement markings on a syringe. So we want to be, with GHB, as I mentioned before, we always really want to be precise with the amount that we're dosing. So the other things you can do if you don't have, there was a paper who referred to the G nurse as a network nanny, which I thought was a super cute idea. But if you don't have a network nanny, you might want to be your own network nanny and take responsibility in terms of setting timers on your phone, things like that. Some people like to keep spreadsheets, The other things you can do if you're a little bit, when people are using, if you want to make sure that there's no sort of exposed sharp edges where people can fall and hurt themselves in that way. So emergencies in that respect, falls and cuts and things, they do happen. So preparing your space is critical. But back to what I was saying before in terms of sexuality and gender diverse communities having good practices of care for each other, I really think that's true. I think we see it play out in a range of contexts, and I'd be really interested for the research sector to be looking into kind of what those practices of care are. I think when we're talking about GHB use, there's data from the Flux study, which I keep referring to, but which shows that GHB use which shows that of the cohort in the Flux study, I think more than half of the people said that GHB use was not acceptable within their friendship networks, and And what that speaks to then resonates with my own experience, which is that you start to see insular friendship networks of people who use similar drugs, and maybe GHB is one of those drugs. And those insular friendship networks, I think, can be really valuable hives of wisdom and care and harm reduction practice. And would be super interested in some strengths-based research to come out to really document what those practices are, so that they can be understood by people and so that they can be applied across different population groups as well.
That's an interesting comment, because one of the things that we anecdotally are starting to be concerned about overdoses amongst other communities for whom GHB is a newer drug, and perhaps there are less experienced elders in the community or other community members to support safer use of a drug like GHB. So we're seeing people put GHB in their alcohol drinks and just drinking it throughout the night and turning up with overdoses in the emergency department with really little understanding of the risk of the combination of those two drugs together and the risk to overdose. And so learning what the particular risks associated with the different drug or the particular effects of a different drug is law that's often passed on, isn't it, from one person to another. So understanding better how to disseminate more safer using messages between community members, I agree with you. I think that's an important thing that we should be looking at. So, I mean, I just mentioned alcohol and GHB, but we know that many people use different drugs, different drug classes and different combinations to achieve different effects. So are there any particular kind of concerning combinations that you like to talk about?
Yeah, I think when we're talking about the GHB, the alcohol and GHB is commonly cited as a combination which can result in GHB overdose. So GHB taken at large doses is a depressant drug, and as is alcohol, and the two don't interact well and can cause overdose. And we also speak to communities about any other drugs with depressant type effects. So, those are things that might not even be immediately apparent to people. So things like Valium or benzos, things like antihistamines with depressant type effects in them, ketamine and GHB is another combination we warn about. I would say that as part of my work with the ACON Rovers program, we do a lot of education with community about that notion of mixing GHB with other depressant type substances. And so it's certainly one to avoid. And really mixing GHB with any other substances can be dangerous. When we're talking about GHB, there's very little way of knowing the purity or strength of the G that's being taken. And we're talking about a drug with such a small margin of error in terms of the dosing. When we're adding other drugs into that combo, then it just opens yourself up to a range of kind of potentially difficult outcomes if you're not really careful. So certainly with the polydrug use and the G, we really advise caution.
Yeah, and I mean, I guess one of the other issues for people is knowing whether you're using GHB, GBL, or 1,4-BD, and they all have slightly different actions. So some are longer acting. So GBL, for example, comes on quicker but lasts longer and is more opposed by alcohol. So people, if they're drinking and using GBL, we've sometimes seen people have a re-overdose as the alcohol wears off out of the system, because then the GBL is because GBL is turned into GHB in the body. So the alcohol competes with it to be metabolized. So when the alcohol goes away, then the GHB kicks in. So we see people actually become re-overdosed. And if that's going on in your body, it's pretty hard to really work out what's going on.
Yeah. Nadine, you probably have like a much more nuanced understanding of clinically what's happening with these drugs than what I do. But certainly, we always just advise caution about mixing with G.
I guess one of the things that we commonly see mixed together is methamphetamine and G and T. And I've certainly come across a number of people who believe that methamphetamine can counteract a GHB overdose. And is that something that you see, that you talk about with communities?
We do look, we come across a range of beliefs about what might counteract a GHB overdose, whether it be, you know, energy drink, whether it be a line of cocaine, you know, different types of uppers. So that's certainly a belief in the community, and it's something that we advise caution about and don't recommend, obviously, because, you know, you're adding more toxicity to your system. You don't, there's unpredictable how that's going to interact. We definitely see that. One of the other myths that we see about GHB a lot in community is that notion that you can't become dependent on GHB, and that feeling that, and I don't exactly know where that comes from, but it might be from that feeling that there's not a traditional come down experience or a traditional hangover experience from GHB. So potentially people think, well, I can't then become physically dependent on it, which we know to be absolutely false.
Yeah, I'm glad that you brought that up, Jack, because certainly in the hospital we do admit people with very severe GHB withdrawals, and people can become delirious quite quickly and end up in intensive care, actually. So obviously not everyone using GHB is going to have that, but certainly about 40 milligrams a day for 3 weeks is probably enough to make someone potentially have a severe withdrawal syndrome. So it's individual, and I'm sure there's people listening out there that say, oh, it's never happened to me and I've used that amount, but we certainly have admitted a number of people with very severe withdrawals. So it's great that you've brought that up. It is something, it certainly is a syndrome that we see.
And I understand the management of that, Nadine, to be similar to how you might manage an alcohol withdrawal. Is that correct?
That's right. That's right. So we usually use diazepam in very high doses, but we also add in a couple of other substances too if people are having severe withdrawal that are only really available in hospital. So it's similar but different. So alcohol withdrawal is more seizure related. It also takes longer you need to have been using alcohol for a lot longer and higher doses before you actually have that kind of withdrawal syndrome than GHB. But the alcohol withdrawal is yet more risk of seizures, less risk of delirium. It's the other way around with the GHB. We're only just starting to learn. We have collectively much more experience in how to treat alcohol withdrawal and help people through it in a safer way than we have with GHB. So we're just starting on that journey, really, how to best assist people with GHB withdrawal. And I've heard from people working in the Netherlands that actually prescribe medical GHB for the treatment of GHB withdrawal. So in decreasing doses, but we don't have that option here. So just quickly in the last few minutes, I just wondered if you could quickly talk about what sort of work you're looking to do around GHB with ACON as we come out of the COVID period.
Yeah, absolutely. And this is a great opportunity to plug a website that I work on called pivotpoint.org.au, which everybody watching should go and visit. Our GHB page is actually our most visited page. People out there want specific tailored information about GHB, so absolutely people should visit it. But we'll continue to do our community education and campaigns work around GHB. We're also interested in how we can do more peer-to-peer education around sexualized drug use specifically, and we're designing up some interventions around sexualized drug use specifically. And we're also thinking about how it is that we might be able to reach our communities in settings where they're using drugs that are not public. So we have some really great programs, and there's been some great investment in programs at nightclubs or at festivals. How are we reaching and communicating with our communities in sort of more domestic settings? So there's a few things on the agenda for ACON in relation to GHB in the next year. Oh, we also have a research partnership with NCCRED, which is important for me to mention considering who we're speaking with. And that research partnership broadly is going to look at some of those questions I raised before around what is the harm reduction practice in our communities around GHB, and what are the strengths there. We're also looking to understand more about how people experience GHB qualitatively, what their language around overdose is, what their understanding of dependence and withdrawal is. So, and across population groups, there's lots of discussion about gay and bisexual men and GHB, and it's long been acknowledged that gay and bisexual men use GHB at higher rates than the general population, but we're planning to look at other population groups as well. So lesbian, bisexual and queer women, and trans and gender diverse people as well.
Yeah, great. We've got
I can't believe I nearly
we have a couple of questions that have come in. I'm sorry, we don't have time to answer them, but we can take them offline and respond offline. I want to thank you for sending them in. They're great questions. We've just run out of time. So thanks, Jack. Thanks for joining me today. It's been a really great conversation and look forward to talking again soon.
Thanks, Nadine. I'll see you later. Thanks for having me.
Bye.